Hey everybody, so we're back for part two of chapter 49. This section of your chapter, we're going to be focusing on adjusting different settings for ventilatory support. So we're picking back up on page uh, 1087. um, we talked a little bit in your first weeks of lab about when you're ever starting a patient on ventilation, or anytime you need to make a vent change, you should always be reassessing that patient completely. And that has a lot to do with the fact that what we know of lung mechanics, you make one vent change that can change other things and impact other things with the patient's breathing. So you want to make sure that you're looking your patient over, inspecting them. Your assessment can include inspection, palpitation, or auscultation. Your assessments of your patients should always include an assessment of the artificial airway and cuff inflation. You should be looking at the patient's vital signs because that will tell you additional information about how well your patient is tolerating the settings that you have them on. You want to inspect the patient's circuit, humidifier, look at the vent settings, make sure that they match the ones in the chart. Look at all those monitored values. And then you also want to be aware of any recent blood gases for the patient and looking at the patient's chest x-ray. So as you guys kind of transition from these student roles into being your own amazing respiratory therapists, I would say getting in good practices of making sure that you're doing a thorough chart review of like x-rays, relevant ABGs, things like that, looking at those orders. When you go and assess your patient, be really, really aware, not just of the beeping, flashing ventilator, but all these other things that are in the room that can impact how well your patient's interacting with that machine. Um, we talked about in the first week, we revisited some, patient ventilator interactions and how those interactions change your waveforms. There's kind of a more in-depth review of that in chapter 48, which we had covered last week, or the week before, excuse me. Okay. When it comes to oxygen concentrations, so this is kind of like your FiO2 setting. This is going to be one of the two settings you're going to change to improve oxygenation or, to adjust for oxygenation issues with your patient. So you have your FiO2 and you have your PEEP setting when you're looking at oxygenation. So the targets for your oxygen should be somewhere between a PaO2 of 60 to 80. So that mildly hypoxemic range is perfectly acceptable, especially because, as you guys may or may not remember from CP Phys, your PaO2 actually, you know, decreases as we age. So you want to keep that PO2 somewhere between that 60 and 80 range. A little bit higher is fine. As your PO2s get much over 90, you should be really considering weaning the patient's FiO2s or their PEEPs. This gives you, saturations above that 90%. So this formula that your book talks about is that simple formula to determine the O2 needs. So you're comparing the initial PaO2s to the desired. So this formula kind of can help you, if you want to be very specific, figure out what you need to change your FiO2 to. I wouldn't be concerned about it for an exam, my exams or the MBRC exams, but just really kind of understand that initially you might be setting your FiO2 at 100%. And but you still want to wean that quickly. So typically we can start our patients on 100%. You're going to start titrating that fairly quickly. You can go down by 20%. So start at 100, go down to 80, go down to 60, go down to 40. And as you get towards your desired PaO2 or saturation, then you want to start going down in smaller increments by like maybe 5 or 10. So when we're titrating our oxygen concentration, we're going to be looking at ABGs and pulse oximetry, or both simultaneously. So typically what I do when I'm setting my patient up, I might put them on 100%, but before I leave the room, I wait to see what my patient stabilizes on. So I might dial in 100%, but I'm not leaving that room until I have them on their kind of final FiO2 setting. So I want to wean it down as much as I possibly can. All right. So the other setting that's going to impact oxygenation is PEEP. Okay. So we usually look at minimal PEEP, or which is kind of the least PEEP that I need to achieve adequate oxygenation. Okay. Or optimal PEEP, which is based on that O2 delivery. Okay. So let's kind of talk about this more in the other slides. So you can use compliance to titrate PEEP. So as you guys should be remembering now that PEEP is going to be used to increase our FRC and open or create stability in those alveoli and keep those alveoli open. So I've shown you this graphic before where you start seeing the big change in volume is at about, I would say that's about 12 of pressure. So if I set my PEEP here, then I know that any change in pressure that I create moving forward is going to create a significant change in volume, which is what we want to see. So you can titrate your PEEP using this pressure volume curve. So you're going to find this LIP, this lower inflection point, and then you are going to adjust your PEEP to usually about 2 centimeters of water pressure above that to make sure your alveoli stay open. You can also be setting your PEEP using a lung recruitment maneuver. So before any lung recruitment maneuver is performed, you need to make sure that your patient's hemodynamically stable, meaning that they have a decent blood pressure. So So typically when you're doing lung recruitment maneuvers, you're going to be using putting the patient in like pressure control ventilation. You're going to set the PEEP pretty high, usually 20 to 25, and a pressure control level about 15 above that. So sometimes I'm going to do like 40 for my pressure control, a total of 40 for my PIP. And then I'm doing that to just try to really open my patient up and recruit all of those alveoli that might be de-recruited at this point. If at any point during that recruitment maneuver, I see a decrease in my SpO2, a change in my heart rate, or a decrease in my blood pressure, any arrhythmias, any other signs that my patient's in distress or having barotrauma, I need to stop that recruitment maneuver right then. Okay, so your book does talk about recruitment maneuvers and gives recommendations for how recruitment maneuvers should be performed. That is on a box on the top of 1094 is that recruitment maneuver, kind of step by step. Okay. A couple other ways that we can look at PEEP and setting our PEEP. There's esophageal manometry, which is kind of a really good method of setting PEEP, but it requires additional equipment. So it's ensuring that PEEP level will result in what we call that positive transpulmonary pressure, which keeps those alveoli open. So this link is a good journal article that if you want to go and read it, that talks about OptoPEEP guided by esophageal balloon monitoring. And kind of gives you more information than your textbook does. Again, it's certainly not going to be on the test, the information that's in this article, but it's kind of a nice reference for you guys, especially if you end up at a site that does do esophageal monitoring. Okay. Electrical impedance tomography is a non-invasive, radiation-free bedside approach to obtaining kind of information from the chest during ventilation. So when you're using the recruitment maneuvers, it can help you identify what's the best PEEP level. And again, I provided a article that talks about this and talks about how to use it. I think it's a free PDF that you can click on. Yep. So you can download this as a free PDF, and it actually shows you the imagery, which is kind of cool. So again, we don't need to get too in-depth into this with the lecture and the information that you need for chapter 49, but I just wanted to provide those additional resources if you wanted to know more information about how those two things are used. Yeah. Okay, this I think is extremely important because I feel like this is always an MBRC question. So this is using tables to identify optimal PEEP. So what this is demonstrating is you're doing like kind of a PEEP challenge where you're putting the patient on 0 PEEP, letting everything stabilize, and measuring like the PaO2 and the compliance for the patient. So I'm going to start at 0, and I see that at 0, I get a PaO2 of 43 and a compliance of 26. Okay. Remember, the higher the compliance number, the better for the patient. The higher the PaO2 number, is better for the patient. So all I need to do when I'm looking at this chart is look at to see what PEEP level, what's the minimal PEEP level I needed to use to give me the best oxygenation and compliance. So when you're looking at this chart, I'm going to give you a minute to think it through before I give you the answer. But if you're looking at this chart, you're seeing that when I go to 5, my oxygenation improves, my compliance improves. When I go to 8, oxygenation improves again, compliance improves again. When I go to 10, I still see that increase in oxygenation, that increase in compliance. But when I go to 12, my oxygenation starts decreasing again and my compliance decreases. So my optimal PEEP for this patient then would be to set my PEEP at 10. Okay. So like I said, the MBRC on your exam for me, you're going to have some sort of PEEP table and you're going to have to be able to identify the information in the table. This is the most basic example of this. The next one's a little bit trickier. Okay. So the next example here, I'm giving you not your compliance, but I'm giving your PIP and your PLAT. Okay, so this sometimes can be really complicated for students because you look at this and you're like, I don't even know what the heck, I don't even know. But if you think about this in terms of I'm on volume control ventilation, my volume's always staying the same. So my compliance, the information about compliance on this chart will really be my driving pressure. Remember, we talked about driving pressure, last week and in lecture part 1. And we want that driving pressure to be less than 15. Okay. So I'm looking through this information here, and I'm looking for the situation that's going to give me the best plat with the best oxygenation. So I look here, my oxygenation continuously improves here. I go, which one is my best, which one is going to be my best driving pressure, my lowest driving pressure. So as I go up here, I know this is my driving pressure is 24 minus 0, so that's 24. 28 minus 5, so that's 23. 28 minus 8, so that's 20. And then here, my driving pressure drops to 17. So 27 minus 10, 17. My plateau, or here, my driving pressure is 29 minus 12, and that's also 17. So these two give me the same driving pressure, but this one gives me better oxygenation. So this one is my better, PEEP. Okay. So when I should probably put I wanted to put a blank slide in here so I could explain this for you again. So just to recap with optimal PEEP and FiO2, right? The things that you need to know is I have an FiO2. I want to keep it below 60%, right? So I don't want to be above 60% for more than 24 to 48 hours. So I want to try to minimize my FiO2 to being below 60%. My PEEP is going to be limited by patient's compliance. Okay, meaning, I don't know why I would put that in parentheses, meaning that I have to go through that optimal PEEP. I can only go up on my PEEP so much before I've overdistended those alveoli. Okay, so once I hit this point where I've used all the PEEP that I can use before overdistending my alveoli or having a driving pressure greater than 15, I'm gonna then have to rely on going back to my FiO2 and increase my FiO2. And also look at kind of alternative oxygenation techniques. All right, so these alternative oxygen techniques will be things like bronchial hygiene. So making sure the patient's sitting up, getting out of bed, walking if possible, doing things like keeping your head of the bed up 30 to 45 degrees. Again, that's to reduce that risk of VAP, that ventilator associated pneumonia. And then also, look at the need for postural drainage, making sure that you have adequate humidification, meaning that you're using heated humidification instead of just HMEs, making sure that if you think the patient would benefit, if they have indications that they would benefit from bronchodilators, that we're doing that, and other types of bronchial hygiene techniques like, Metaneb and chest PT, things like that. So, finally, the last thing that we kind of talk about when we're talking about oxygenation techniques is prone positioning. So many of you have probably done prone positioning before. This has kind of had its like a revitalization of usage since COVID. So prone positioning has been proven to increase your PaO2 levels and decrease shunt fractions. It also helps reduce mortality in severe ARDS patients. It's one of kind of the few things that has been proven to be beneficial to ARDS patients. Um, so going back to kind of some of that CP Phys stuff of it, if you think about your ARDS patients, your dorsal alveoli, this means the ones that are located towards your back, in the supine position above here, most of the gas and blood in those, most of the gas and blood flow to those dorsal injured areas, and then that shunt is going to increase. So gas is going to be up here. Those dorsal areas are not going to be ventilated very well. The blood is going down here. So all the areas that are getting ventilated aren't getting blood flow. So that's going to increase that amount of shunt that's happening. In prone positioning, most of the gas and blood are going to go to like those dependent areas where the healthy lung tissue is. So you're going to have better ventilation and perfusion matching. So I think this visualization over here, I felt like was very helpful of just kind of understanding how ventilation is affected during prone positioning and perfusion. There are quite a few serious complications related to prone positioning. Most of them have to do with, facial edema, swelling, and skin breakdown. That's a huge part of it. But they also talk about just what am I trying to think of? So most of them have to do with like skin breakdown. There's corneal abrasions as well. Sometimes patients don't tolerate it, and you'll see that they'll kind of have like hemodynamic instability, or become very agitated or have a lot of pain with prone positioning. So a lot of times, we'll flip them over. We'll try to give them a minute to settle in, but you might have to flip them back. There's kind of an optional video link that I included on the main page that you can watch to get more information about this as well. Okay. So moving on to ventilation, we've talked about how ventilation is determined by respiratory rate, tidal volume, and then the patient's physiologic dead space. Okay, so we calculate out that alveolar ventilation. We've done this a million times by taking the total tidal volume delivered, subtracting the dead space, and multiplying it by the respiratory rate. Okay, so your arterial CO2 is going to be considered kind of that metric that we look at for effective ventilation. So if I increase my alveolar ventilation, my PaCO2 should decrease. If my body produces less CO2 through, you know, by managing their nutrition to limit their carbohydrates, that then our bodies don't produce as much CO2, and that's going to decrease the amount of CO2 that's in my blood as well. So there's two kind of things that affect that. Those ventilation adjustments, then if everything stays the same with CO2 production, how much metabolism my body's going through, how much it's producing, if things are kind of staying stable with that, then any adjustments that I make to my alveolar ventilation can make predictable changes to that CO2 level. So if I want to calculate this out, I can take my initial CO2, multiply it by my initial frequency, and that should equal my desired CO2 at my new frequency. Okay, so we can do this calculation out together in lab, but that's how you kind of can make this predicted, same thing with tidal volume. That's how you can kind of make these predictive changes. Remember as well, when it comes to ventilation, the goal is to normalize your pH over normalizing your CO2. And that's because normal patients are going to have those pHs within that normal range, CO2s within that normal range. But you're going to have some patients who have like COPD. These patients have very, very high baseline CO2s or low pHs. So I'm looking more to try to get that pH within that 7.35 to 7.45 range, even if it's at the lower end of it, than trying to get my CO2s within 35 and 45. Your ARDS patients, this might be impossible. You think about ARDS and the fact that these patients have very, very poor compliance. So those alveoli don't want to remain open, meaning that I'm going to need to potentially apply a lot of pressure to those alveoli to get them to open up and stretch and get a good volume in. Well, those pressures are going to go do damage to those alveoli. So by using lower tidal volumes, lower tidal volumes, I'm going to be protecting those patients from further damage to their lungs, further inflammation. But that might result in me not being able to ventilate these patients within this normal pH range. And that is called permissive hypercapnia. When we intentionally go, hey, I know you're not between 7.35 and 7.45, and I'm okay with that because if in order for me to get you here, I would be using way too much pressure. Okay. So when you're doing permissive hypercapnias, you can see CO2s even up into the 70s. The pH will be acidotic. There's other medications and things like that we can give patients to try to normalize that pH so that we're not, we don't have the huge electrolyte issues, but we're not going to try to fix it with ventilation because we're accepting those abnormal values in favor of protecting the lungs. So adjusting your tidal volume and rate. Remember, your tidal volumes are going to be patient specific. We want to keep our plateau pressures less than 30. So you can use a larger tidal volume, those 6 to 8 milliliters per kilogram for patients with normal lungs, smaller tidal volume, somewhere between that 4 to 6 for those patients with lung injury or ARDS. So if your patient is apneic, you can have very, very precise controls of the CO2 because the patient's not going to be breathing over what you have them set at. Okay, again, you can use this formula to kind of predict it, plug in those values. If you use a respiratory rate of 18, and that gave you a PCO2 of 50, so PCO2 of 50 times 18, and I want my PCO to be PCO2 of 40, I just plug these in. 50 times 18 should equal 40 times whatever the new frequency will be. If I do the math out, that gives me a respiratory rate that I should be setting of around 22 to 23. Okay. I might look at that then and go, ooh, that's above 30. I don't want to use a respiratory, or excuse me, above 20. I don't want to use a respiratory rate above 20. I'm not going to make this change. Instead, I might go up to rate of 20 and then increase my tidal volume as well to try to achieve that minute ventilation that I want. Okay. So if tidal volume is changed, again, that PCO2 is also going to change predictively. You can use that same calculation. So if my initial PCO2 is 30 and I had a tidal volume of 600 there, my desired PCO2 is 40. I know that I need to reduce my tidal volume by 450 to achieve that. Right. So again, we're always selecting that tidal volume based on the patient's ideal body weight and their condition. Most of those patients are going to be in that 6 to 8 milliliters per kilogram. Some patients are going to be in the 4 to 6 if they have like ARDS or really poor lung compliance. We can also, when we're in IMV modes like SIMV, we can also use pressure support to help minimize the work of breathing for those spontaneous breaths and achieve higher tidal volumes. Okay. So if I'm using IMV, when I'm making my settings and making my adjustments, I'm going to set my tidal volume to an appropriate level within that for the patient. Then I'm going to monitor my patient and observe as I adjust the pressure support, what volumes that they're achieving with that pressure support setting. Okay. So I'm going to be evaluating not only those mechanical volumes that the vent's delivering, but I'm going to be looking at those spontaneous volumes that my patient's achieving with the pressure support that I have set. If those volumes fall below 4 milliliters per kilogram, I would increase my pressure support to get those volumes to be a little bit higher so my patient doesn't have such a high work of breathing. Once I've set that pressure support to achieve those volumes somewhere between 4 to 8 milliliters per kilogram, then I'm going to just increase or decrease that set rate to adjust the PaCO2. So again, and again, we did this in lab, so hopefully it makes more sense as you're watching this. Once you kind of have that tidal volume set for the patient, you're going to rarely kind of change it. Most of the adjustments are going to be made with that respiratory rate until you kind of max that yourself out with the respiratory rate, and then you have to go back to making potential adjustments to the tidal volume or deciding, hey, I can't adjust anything and I'm just going to let the patient be a little bit hypercapnic. AC mode, volume ventilation, and PCO2. So again, you're setting the tidal volume based on the patient's ideal body weight and condition. You want a rate of at least 10 or probably 12 to ensure minimum ventilation. The patient with that intact respiratory drive will trigger the ventilator to help achieve their desired PaCO2. You can have patients end up hyperventilating, though, in AC mode more so than even SIMV, because every single time the patient triggers a ventilator, they're going to get a breath and a full big breath. So if the patient's in a lot of pain and breathing quickly because of pain, anxiety, or kind of the need to suction, they might have a really fast rate, and that could cause them to hyperventilate easy and drop their CO2 levels. So if you see that, the patient having hyperventilating on their blood gases where their CO2 is really low and they're in AC, make sure you corrected any underlying problems. And then ultimately consider sedation or analgesics. Like the solution to troubleshooting your patient your first answer should never be just go get the Versed and knock this guy out. It should be, let me just look at all the other things, make sure that my vent is synchronous and interacting with my patient appropriately, make sure that my patient doesn't have any other underlying pain or anxiety that's causing them to be tachypnic. Sometimes patients with fevers can end up being very tachypnic. do those things first before just resorting to asking for increased sedation. Okay. Again, this is just reiterating the fact that your pressure support should be set at a level needed to establish a good tidal volume per their body weight. Okay. If I want to increase or decrease their tidal volume, I could just simply increase or decrease that amount of support that I'm giving. Okay. If your patient is in pressure control mode, okay, this is something that you guys forget a lot when it comes to testing because we're so used to seeing patients on volume control. If your patient's on pressure control, remember you're using the pressure gradient to create that volume. So, kind of the same theory as how we're adjusting pressure support. I'm setting my pressures. Again, I want to do it to keep my pressure below 30. Um, but my plateau pressure below 30. But I also want to make sure that I'm achieving a tidal volume within that range. So if I set a pressure limit of, let's say, 25, and I look to see, and their tidal volume that they're achieving on that 25 is averaging around 6 milliliters per kilogram, I might be like, oh, that looks good. But let's say it was averaging around 9 milliliters per kilogram. I'd be like, oh, 25 is too high. I needed to reduce that. So let's now go down to 20. Again, observing those tidal volumes. If I went down to 20, now they're falling within that range and they're about 7 milliliters per kilogram. Now I know 20 is a good level for my patient. Um, just, I think that's what I want. Oh, just again, to remember that eye time is also going to affect the volume delivered. So I can, like these two, this is my crappy drawings, but these two graphics are supposed to show that, okay, I'm using the same pressures, pressure control here and here. Let's say it's 25. Oops. So this is a pressure control of 25. This is a pressure control of 25. Okay. So it's not just what my pressure gradient's set at that creates the volume in my patient, is also that time. So here you see that I have a much longer eye time set, which is achieving a much bigger volume because I'm spending a longer time applying that pressure to the lungs. So I have more flow going in. My patient is getting a bigger breath. Over here, as I shorten my eye time, that's going to reduce my volumes delivered as well. So again, it's not just my pressure gradient. You might also need to be looking at eye times to make sure that that's not what's shortchanging your tidal volumes. Okay, when thinking about using your PCO2 and your ARDS patients for ventilation strategies, we want to be lung protective. We want to avoid that overdistension. We are doing that by keeping our plateau pressures less than 30. Oops. Overdistension occurs when plateau pressures are greater than 30, so we want to keep it less than 30. We do this by doing something called the open lung approach. And you might have learned about this or looked at this a little bit more when you did your ARDS patient in Jim's class. That open lung approach is using those high PEEP levels to open that alveoli up and low tidal volumes to ventilate. Okay. Usually this can be done after like a poster recruitment maneuver because then we've opened everything up. Now we're just trying to keep it open. Remember, the tidal volumes that you choose are going to affect the respiratory rates that you choose. So if you're using a lower tidal volume, you might need to increase your respiratory rate to achieve the same alveolar ventilation. Um, you are, though, limited with how fast your rate can be, because eventually, no matter who the patient is, you make the rate fast enough, you're going to have some level of auto PEEP. So if you are maxed out on your tidal volume, because if you go up your tidal volume, your plateau pressure is going to be too high, and your rate's maxed out because if you go up on your rate, you're going to have auto PEEP. That's when you're going to start considering using permissive hypercapnia. Okay. So there's some other lung protective strategies that are out there. When patients are really, really bad, they will just remove the lungs and the heart from the equation and do something called ECMO. So ECMO is extracorporeal CO2 removal. There's a whole chapter in your Egan's book, but we're not going to go that deep into it. This semester, it's looking at taking the blood out of the body. So you have venous ECMO. As example of that is that they have a catheter in a vein that's pumping the blood out of the body into this ECMO machine that's at the bedside. That ECMO machine provides oxygenation to the blood, removes CO2 from the blood, and then pumps it back through another vein to come back to the heart, and the heart then pumps it out to the rest of the body. So this venous ECMO really just bypasses the lungs, takes the lungs out of the equation. Okay. Veno-arterial ECMO is where blood is again pulled from a vein, and then it's sent through the ECMO machine to get oxygenated, remove CO2, and then it's sent back into the body via an artery and gets pumped again throughout the body. So ECMO is doing the work of the lungs just externally. Okay. I think we've talked about this a bunch of times. There's only a few ECMO centers in the state of Wisconsin, so patients are limited as to being whether they get this, if it's accessible to them. So if you live up in the UP, you're probably not going to ever get ECMO. But if you live right next to Froedtert or right next to UW-Madison or Marshfield, I think Marshfield Clinic's the other one, they have ECMO machines, perfusionists, and I think respiratory, maybe at Froedtert or Children's might be involved in ECMO. But this is just kind of an extreme measure to help with patients that have very, very, very non-compliant lungs, problematic lungs. It's just an extreme measure of just taking over that job completely with this ECMO machine at the bedside. Okay, some other lung protective strategies revolve around reducing the amount of CO2 that we produce. So, if your patient has a fever, they're going to be producing more CO2 because they're going to be metabolizing more. Their metabolism's increased, so their CO2 production's increased. So we want to manage their fevers, avoidance of those overfeedings, like we've mentioned before. Carbohydrates increase your CO2 production. So, dietary usually takes a close look at how much carbohydrates and high fats and things like that are in our critical care patients' diets. And then neuromuscular paralysis, because kind of the final way that we do this. Usually patients with severe ARDS, this is another proven mechanism to help with that, is if we paralyze them for 12 to 48 hours, that helps stabilize the patient, that helps decrease their oxygen consumption, CO2 production, and helps us manage their oxygenation and ventilation more. All right, that is it for part 2. Like I said, this one was going to be shorter. I promised you a shorter one since the first one was so long. Hopefully this all makes sense after, you kind of practice some of these key concepts in lab during your second week of this module. And if you have questions, please don't hesitate to reach out.